So we want to go ahead and welcome everybody to today's Grand Round session. It's August 11th and your event code for today is 223047. Please make sure that you do register for your CME credit if you're looking for that before midnight tonight. I will continue to put that information. I'll put it for those who continue joining in the chat box there. But make sure you do that before midnight tonight. Next slide. And so as we get started here, if you can make sure, if you haven't already, please make sure that your microphone is muted and be attentive and engaged in this session. They have asked that we put the questions in the chat box and then we'll address those at the end of the presentation. And then also in the chat box, I'll be putting the evaluation for our presenters. I'll put that link in the chat box for us towards the end. Next slide. So this is the South Texas Regional Family Medicine Grand Rounds, and we are partnered with the South Central Area AHEC, and our mission statement is there for you. Next slide. CME transcripts are available. You can visit the office's CME website, and if you have any questions, please feel free to contact them, or you can reach out to me as well. Next slide.
I'm hitting next slide, and it's not going anywhere. There it goes.
All righty. For those wanting AAFP credit, please make sure that you do turn in your CME transcript to them so that you can get your credit for that. But again, if you need help, please contact them or you can contact me as well. And so we want to make sure that we do mention to everybody that the FCM Grand Rounds addresses these nationally established physician core competencies, which you can see here, but let me know if you have questions about those. Slide. And so Dr. Huehn and Dr. Solis are our presenters for today. They have no financial relationships with ineligible companies to disclose, and they're going to present for us today. And so on the next slide here, we're going to be discussing musculoskeletal medicine and the role of the physical therapist. So they are here from our physical therapy department, and they're going to go ahead and present for y'all today. And I will let Dr. Huehn take it away.
Thank you so much. We really appreciate the opportunity to be with y'all today. Just a little bit more about what we're going to be talking about. So hopefully we can end this hour with a little bit more explanation of just how we play into the role of the healthcare team and hopefully how we can assist you in your roles as primary care providers. And we're going to highlight just a little bit of the concept of the musculoskeletal assessment. We're going to go through a little bit of some screening strategies, just talk a little bit about what you can do in the clinic and some things that we look at here in the physical therapy clinic as well, and hopefully just inform you a little bit more about who we are and what we do. So physical therapists are considered the movement experts. So that's our role in the healthcare continuum. We work on creating treatment plans to help people improve mobility, manage pain, chronic conditions. We see a lot of postoperative patients, and we see patients across the spectrum of medical conditions. We'll be able to tell you a little bit more about that in the next few slides. These are just some slides from our professional organization, but show a little bit more about all the different patient types, from pediatrics to geriatrics to orthopedics to neurology. We see a little bit of everything, and we do treat all of those patient types here specifically at UTHP as well, UT Health Physicians. We are doctorally trained. We have a Doctor of Physical Therapy degree. As all other healthcare providers, we have to pass a state licensure exam. Most post-professional DPT programs are 3 years post-baccalaureate. We study a lot of similar things as you: anatomy, physiology, biomechanics, kinese, pharm, pathology, endocrine, metabolic, musculoskeletal. We look at the entire system, but really that human movement, the body and the musculoskeletal system is our kind of primary area of expertise. So we're really trained to be experts in movement dysfunction. Again, how are we trained? We have not only that 3-year post-baccalaureate, but there's also postdoctoral fellowship and residency programs available for therapists. And board certification is also available in cardiopulmonary, clinical electrophysiology. There are physical therapists who do nerve conduction and EMG testing, geriatrics, neurology, oncology, orthopedics, pediatrics, sports, women's health, and wound management. So as you can see, we can be board certified and work across the spectrum of the healthcare continuum. Just a little video here, hopefully get your little motivation for this Wednesday morning.
when the explosions happened and my leg was gone, my biggest thing was, number one, staying alive. I mean, I really did think that that was it for me. I thought that my quality of life would be a zero. Mustering up the gut to be able to actually do it and feel my limitations was so tough. It was more mental than physical. My physical therapist completely understood that and knew that I needed the mental capacity to be able to do it. And she just kept my eye on the prize. Physical therapy means everything to me. You know, my physical therapist taught me how to walk again. And that taught my family and people around me that I was physically able to do anything that I put my mind to.
Okay, so there's our little warm fuzzy reminder of why to choose physical therapy. All right, so today we're going to be talking about musculoskeletal assessment. When I first put this presentation together, I was asked to give a discussion on musculoskeletal assessment for the primary care providers, specifically primary care sports medicine residents. So when I initiated that, I just started diving into the research of what's out there, because as a physical therapist, I have not been to medical school. So I had no idea what the musculoskeletal training is in the medical school realm as far as musculoskeletal medicine for the primary care physician. So the next handful of slides are going to go through that, a little bit of sharing with you what I found and some interesting studies that I found, just trying to learn a little bit more about not only what is the training, but also what is the perception of most medical school students and residents on their comfort level assessing and treating musculoskeletal disorders. This quote here just came from the American Academy of Orthopedic Surgeons that talks about musculoskeletal complaints are the most common reason patients visit primary care physicians in the United States, but significant evidence indicates that most primary care physicians do not feel adequately prepared to address such complaint. So great timing to have such discussions as this. I'm wondering if there's a little way I can minimize this at the top of my screen. Why is understanding of musculoskeletal pathology so critical? According to the United States Bone and Joint Decade, 50% of disabling conditions in the United States are musculoskeletal in nature. And in 2012, contributed to 16 million lost work days. 15 to 30% of medical office visits are for a musculoskeletal complaint, leading to a total cost of $848 billion. So clearly very relevant of a complaint that patients will be coming to see you in your clinic for. So this is an old study, but this study was sort of regarded and continuously referenced in my deep dive into this topic as a repeatable and replicable study on basically musculoskeletal competency in primary medicine. It's really considered kind of a hallmark study. It's referred to now as the Friedman and Bernstein exam. But this was one of the initial studies done by the Journal of Bone and Joint Surgery way back in 1998 that talked about the topic of how comfortable are primary care physicians with musculoskeletal topics. So they came up with this basic musculoskeletal competency exam and gave it to 85 postgraduate surgical and medical residents at the University of Pennsylvania School of Medicine. Some of the sample questions, and I want y'all to think through in your head if you'd be able to rapidly pop out the answers to these. Since we are not meeting in person, I can't quiz anybody. Some of the sample questions are: what muscles are involved in lateral epicondylitis? What is the primary function of the ACL? And when are radiographs indicated for low back pain? In this initial study, they found that the mean score amongst their medicine residents was 58% on this 25-question basic musculoskeletal exam. And the failure rate amongst the medicine residents was 87%. So this raised a lot of eyebrows, and this study was redone in multiple fashions and across different settings repeatedly. Just to highlight a few that built upon this, in 2005, same journal, similar musculoskeletal competency exam was given to 334 residents and staff physicians across specialties. The average score was only 57%, and 79% of them failed the exam. In 2006, It was completed by 92 primary care physicians, 64% of them failed. And the surveyors also determined that the self-perceived confidence in musculoskeletal medicine was found to be much lower than general medicine, which really goes hand in hand with the research and the consensus that was coming through in my findings that just found that the amount of education in the musculoskeletal system was lower than general medicine. Another one done in the American Journal of Orthopedics found that they did a survey of 680 family medicine residents at 100 different medical schools, basically to assess their confidence level in a physical exam, radiographic evaluation, diagnosis and treatment of a variety of musculoskeletal disorders. So again, 100 different medical schools. Family medicine residents reported low confidence in musculoskeletal management compared to non-MSK pathology. Another one sampled 5,000 graduating family medicine residents, and they, quote, reported poorly or very poorly prepared in musculoskeletal medicine. Last one, this one was done in the Academic Medicine Journal in 2007, looking at Harvard medical students to rate, again, looking at their confidence, their self-perceived confidence in musculoskeletal medicine and education. 2, 7, and 26% respectively of second, third, and fourth year medical students passed a nationally validated competency exam. And they rated their clinical confidence as inadequate to poor. So clearly there seems to be a general perception across the board in a lot of medical education that musculoskeletal confidence and competency seems to be low. Maybe many of you have heard, have maybe been around as long as some of us of the bone and joint decade. But basically this was an initiative launched by the World Health Organization and endorsed by the United Nations to bring to light in the medical model the issue of bone and joint disorders. It was a campaign that was initiated in 2000 and ran for a decade, and it looked at the socioeconomic costs of musculoskeletal conditions, and it was really designed as a global, multi-international initiative to address the treatment and understanding of musculoskeletal diseases. And they partnered at the end of all this to help identify educational objectives for US medical students. So this is a conversation clearly that's been happening for a long time. And one of the conclusions in this was a board of directors resolution adopted by the AMA. And I won't read all this to you, but basically it says at the very end, if you look, it says to promote higher standards in basic competency and musculoskeletal care and accreditation of medical schools. Again, it says at the beginning, it strongly urges the medical schools to reevaluate the musculoskeletal condition or curriculum. So again, I wish we were in person in some senses so I could get some feedback from some of you of just how well prepared do you feel in musculoskeletal training from our own medical school. But this was in a bulletin from the World Health Organization back in 2003 that said musculoskeletal training in medical schools and residency programs throughout the world is inadequate. So we really appreciate opportunities to participate in this dialogue and be able to hopefully give a little bit of just some of the background of things that we learn in our training programs as far as musculoskeletal assessment, but also hopefully just increase the partnership between medical providers and physical therapy providers to help utilize us to assist in musculoskeletal management for your patients. So when we talk about a basic musculoskeletal screen, very grossly, we look at a global movement screen. Upper and lower extremity joint motion, you can assess overpressure. It's important to look at the scapula with any type of shoulder condition. Functional movements, looking at someone's ability to do a functional squat. Can they heel walk, toe walk? Very gross movement screens, which can give you a good bit of motion through a very quick assessment. Spinal motion screens, balance, can they stand on one leg? Anything less than 10 seconds is considered a pretty high fall risk. And it's remarkable how many people have a very difficult time doing that. Just doing basic strength testing, peripheral nerve screenings, and then there are hundreds of special tests that could be available if needed. When you're looking at a musculoskeletal screen from that global screen, then it can be broken down to more specific regional screenings, which are really based on symptoms or complaints. With any primary peripheral joint complaint, it's always important to look at the joints above and below the area of complaint as well. So if someone has a shoulder complaint, important to look at the elbow and the neck as well. Again, movement screens, taking a lot of functional movement patterns that individuals utilize in daily life and simply assessing them. Can they lunge? Can they squat? Can they go up and down a step or various stairs? In our athletes or anyone coming in complaining who participates in a throwing sport or overhead activities, looking at their throwing mechanics, looking at overhead joint mechanics. Can they jump? Walking, running. This ties into often a lot of sports screens, but also work-specific screens or things that are important that we look at in clinics as well. Balance. So many of you probably see balance dysfunctions. Balance is very, very important and something important to address to hopefully keep people out of progressive injuries as a result of balance dysfunctions. We have a little bit of some examples of basic screens that we utilize here in the clinic as part of our examination.
Yep, so we're going to look at several movement patterns and decide if they are acceptable or not. If they are acceptable, we're going to leave them alone. If there's any problem, we're going to dig into that pattern and figure out what is going on. For each pattern, we have a breakout exam that will tell us why the movement pattern was dysfunctional. The breakout exam will let us know if they have a mobility or stability deficit that is preventing them from performing the movement or affecting the movement quality. Now we're going to define dysfunctional as any movement that does not meet the criteria as defined. So if you look here on the video on the left, this is Kelsey. She was one of our former techs that has since moved on to PT school. Go ahead and start. Okay, the first movement pattern that we're going to be looking at is coming from the cervical spine. I'm going to have her basically perform flexion, extension, and rotation. And I'm going to pause in between each movement just so that we can discuss the criteria we're looking for.
Okay, back again.
All right. Okay, so we're going to look at cervical flexion first. Sorry about that. Let's see. Okay, it's not pausing.
Try just clicking it a second time.
All right. Okay, so cervical flexion. What I'm looking for here is first thing is, can she bring her chin down to her sternum? That's the first requirement we're looking for. You can see she does accomplish that. We're looking for a good uniform curve in her cervical spine. And we're also watching to see if she can complete it without excessive effort or any lack of control. I would say I wouldn't say there's any problems with this movement, so we're going to move on to the next one. So here she's going to go into extension. What I'm looking for is at least 80 degrees of motion. So if we were to draw a line from her forehead down to her chin, it would be pretty close to parallel to the ground. So at least 10 degrees from parallel would achieve the 80 degrees. Again, we're looking to see if she can do it with good control without any excessive effort. I don't see any problem with this movement here. The next motion is going to be rotation. Now for rotation, I'm also looking for 80 degrees of motion. A quick screen would be if I were to draw a line from her chin or her nose down to her clavicle, I want it to be in line with the clavicle or slightly past it.
Some technical issues with our video. So we'll let it get back to that rotation.
Okay, yeah, so if I were to draw a line here, she's pretty close to that. I mean, I would probably actually have to measure to see if she's completing 80 degrees. But in this case, if it's a close call, I would rather just rule it dysfunctional, break it out, and see if I'll be able to determine if it was a problem or not in one of our breakouts. So this would probably be the first movement that I would be taking into account to look at it a little bit closer. She's also going to repeat to the left side, and the left side was pretty similar. Okay, so next we're going to move on to the shoulder. First thing I'm going to have her perform is functional external rotation. So I'm going to ask if she could reach overhead and try to touch her opposite scapula, the spine of the scapula. It's going to be important to see if she can perform this in a good smooth motion without any compensation. She did have some restrictions. So one of the things you're going to notice is she's going to flex her head forward in order for her to accomplish it. So she's able to reach the scapula, but you can see she has to flex her head. So there's a little bit of compensation here. So I would rule this movement pattern dysfunctional. Then we're going to move on to the other side. Now, with all these movements, I'm also asking if there's any pain involved. So I want to determine, is the movement acceptable or not, and if is there any pain associated with any of the movement patterns. Saw the same thing over with the left side. She flexes her head forward. So the next movement I'm going to be looking at is functional internal rotation. So now I'm going to have her reach behind her back and see if she could touch the opposite inferior angle of the scapula. I'm checking to see if she could complete it in one smooth motion and not breaking it down like shoulder extension, then elbow flexion. You're going to notice that she does have to break it down a little bit and goes into slight radial deviation. So I would also rule this one dysfunctional. And we're going to look over at the left side. Now, we weren't able to see it on the right, but another thing I also noticed with Kelsey is that she does get a little bit of scapular winging, and that would also warrant a closer look. Okay, so moving on to the next movement patterns, we're going to be looking at the lumbar spine. The very first movement she's going to perform is called multi-segmental flexion. I'm basically just going to have her reach down, try to touch her toes. The criteria I'm looking for here is, number one, can she touch her toes? She doesn't meet that requirement. I'm also looking for a good uniform curve of her spine. So if you look at her thoracic spine, she has a pretty good curve, but when she gets down into the lumbar region, she kind of flattens out. I'm looking at the sacral angle to see if her sacral angle reaches at least 70 degrees. She is short. And I'm also checking to see if she gets a good posterior weight shift, and that she does. So out of all out of all that criteria, the only one she did meet was the posterior shift. So this is another one I would rule dysfunctional, and I would be breaking down later in the examination. Now, now looking at this pattern here, I want you to keep in mind what do you feel is preventing her from reaching over and touching her toes. I'm actually going to use this as an example in a little bit, just to show an example of a breakout pattern. But if we stop and think of what are some things that she needs in order to accomplish this movement, I want you to think about that for a minute, and then keep that answer in mind for when we come back to it. Okay, the next movement we're going to look for is multi-segmental extension. So I'm going to have her extend her spine. The very first thing I ask her to do, though, is I want her to be able to flex her shoulders to at least 170 degrees. As you can see, she's well short of that. So already I would rule this movement pattern dysfunctional. But I'm still going to have her proceed with the rest of the movement just to go ahead and see if I pick up on anything else. Another thing to keep in mind or to consider here is if we're lacking shoulder flexion, what are some key areas that she might compensate with that can lead to problems? Like say she wants to reach over up on top of a shelf. If she's lacking the motion here, where do we feel that she may compensate? One of the most common areas is going to be the lumbar. A lot of times when we're lacking shoulder flexion, one of the compensatory strategies we're going to use is extending at our lower back. Okay, but we're going to go through the rest of the movement. Okay, so I'm going to pause it here. Aside from the shoulder flexion that I'm looking for, I'm also looking at, if I were to draw a line from her ASIS down to the ground, I'm checking to see if it would go beyond her toes. On the back side, I'm looking at the spine of the scapula, and if I were to draw a line from there down to the ground, I'm checking to see if she crosses the heels. So there's some other requirements that would be needed in order for the movement pattern to be deemed acceptable. I'm also looking for a good uniform spine of her curve. Now we can't see it here, but she does tend to hinge more at one segment in her lumbar spine. So this is another movement pattern that we ruled dysfunctional. Next one we're going to look at is rotation. Now I like to stand behind them for this movement, because when she rotates over to the side, one of the things I'm looking for here is can I see the opposite shoulder peek through? We want a total of 100 degrees of rotation. So 50 degrees should be coming from her thoracic spine. The other 50 should be coming from her pelvis. She does fall short of the full range, so this would be deemed dysfunctional. And we're going to move over to the right side. And the right side, she's actually a little bit more restricted. And it kind of seems like it's coming more from her pelvis than the thoracic, but I would still want to break it down just to make sure. Okay, one of the movement patterns that's not pictured is just a single leg stance, where I would have them stand on one leg and see if they could do it for at least 10 seconds with both eyes open and eyes closed. And if they're unable to, it would be ruled dysfunctional. The last pattern is going to be a deep squat. Now for this one, I'm having her squat down with her feet together. I know none of us ever squat that way, but it's just a quick way for us to be able to assess if there's any compensation that sometimes we may not pick up on if they do a regular stance squat. But what I'm looking for is, can she come all the way down? Does she stay within the sagittal plane? And if she does make it all the way to the bottom, the next step would be for her to bring her arms down to her side. If she's unable to maintain her balance during that movement, then I would rule the movement pattern dysfunctional. So she doesn't reach all the way to the bottom in this one. Okay, so those are the movement patterns we're looking for. Now we're gonna go ahead and break down one of the patterns here. So going back to what we talked about earlier with this one, just to recall here, the criteria we're looking for is, can she touch her toes? She can't. Does she have a uniform curve in her spine? She's a little more flat on the lumbar. Her sacral angle doesn't reach 70 degrees. So we'll be breaking out this pattern and see if we could determine what's causing it. Now, if we think about what do we need in order for us to be able to perform this movement? Well, one of the things we need is good posterior chain flexibility. So we need good flexibility in the hamstrings and glutes. We need good spine mobility. We need to be able to flex through the spine. And we need good hip flexion, right? Because if we have a mobility restriction preventing hip flexion, it's going to affect our ability to reach forward. So in standing, she's in a weight-bearing position, right? She's weight-bearing through her legs. Her spine is a little more loaded in that position. So the very first thing I'm going to do is I'm going to remove her lower extremities. I'm going to have her sit up on a table, so we're no longer weight-bearing through the legs. Her spine is still going to be somewhat loaded here. But if you look at her movement, you can see that she gets a little bit further here in this position. So just from taking her out of that weight-bearing position, we see an improvement. She's still not able to touch her toes. Other things I'm looking for here is now the sacral angle. I'm checking to see if she can get at least 80 degrees. It does look like she obtains the 80 degrees here. I'm looking at the spine curve. Still flexes pretty good to the thoracic spine, but you can see in her lumbar that she's still pretty flat. So it doesn't pass the criteria here on this movement. I'm no longer looking at the posterior shift from the hips because she's sitting down. Okay, so we're gonna move on. I'm gonna have her lie down. So now her spine and her lower extremities are no longer loaded here. Okay, so first thing I'm gonna have her do is now I want her to actively lift her leg into flexion. So I'm gonna have her perform an active straight leg raise. I'm placing my hand under her opposite knee just to make sure that there's no compensation. Now, what I'm looking for here is I want to see if she can get at least 70 degrees of range of motion. She does fall short of that. It looks more like 45 to 50. This probably isn't the greatest camera angle. It'd be easier if we were directly on her side to be able to see the range. But at the window pane back here where her foot ends up, I want you to pay attention at. as we move on to the next steps. But okay, so does it meet the 70 degrees here? I'm going to look over on the left side. Okay, same thing. She doesn't get the 70 degrees on the left. Let's pay attention to where her foot ends up with that window in the back. So actively, she was unable to meet the criteria I'm looking for. So what I'm going to do next, I'm going to give her some core stability. I'm going to have her engage her core by her pushing down on my hand. It's helping her engage her core, and it helps her flatten out her back a little bit, get a little posterior pelvic tilt. I'm going to have her repeat that active straight leg raise. I have her bring her legs down. And now she's going to go ahead and lift. Okay, so I know I'm blocking here a little bit, but if you pay attention to back here, the window pane, she does come up a little bit higher. I'm still looking for the 70-degree angle. I'm going to repeat it on the other side. Now, we have tested Kelsey in the past, and we actually did take measurements, and her measurements with the active straight leg raise were 60 degrees. When we gave her some core stability, she was able to get 80. The day we recorded, she was actually wearing some tighter pants, so that also played into some of the restrictions here. But she went from 60 degrees to 80 degrees just by giving her some core stability. Now, I looked at active and I looked at stabilized active range of motion. So what I'm going to do next is I'm going to take her up passively because I want to compare her range here. What I'm looking for in this range is at least 80 degrees. So I'm just a bit. Okay. So I'm looking for 80 degrees. If you can see, she's probably pretty close to 90, but we did measure her and she's at 90. So I don't know if anybody was maybe suspecting the hamstrings when we initially had her bend forward and touch her toes. Will we still think that the hamstrings is what's causing the biggest issue? As you can see here, she does have pretty good hamstring flexibility. So it's not necessarily the hamstrings. We're going to look at the right side. Okay, yep, and the same thing. She gets pretty close to 90 here. So I would consider this passing, but if she can only get 60 degrees of active range, it improves 20 degrees by giving her a little bit of stability. She has full range to up to 90. So that means that from 60 to 90 degrees, she doesn't have very good control of that movement. So it's not necessarily a mobility restriction. It's more that she's lacking some stability and motor control. So I would definitely want to be working to improve her strength and stability to help improve that movement pattern. Okay, now other things that we're considering is her hip flexion, right? Because if she has a hip flexion mobility restriction, it's going to affect her ability to flex forward. What I'm looking for here is looking at hip flexion. I want her to get at least 120 degrees, and she does. So there's definitely no problem with her hip flexion. So we can definitely rule that out. And the last thing I'm going to look at is her spine. So we want good spine mobility. She needs to be able to flex through her spine. Now she's here she's not in the standing weight bearing position. So I'm going to look at, I want to see what it looks like here in this position. You can see she still has a good uniform curve in her thoracic spine, but her lumbar spine still remains pretty flat. So if I were to give her a movement diagnosis that's preventing her from completing this movement pattern, it would be a lumbar flexion mobility deficit and a core and active hip flexion stability deficit. So my manual techniques and my exercise prescription are going to be geared more to improving those key areas. And having a movement diagnosis helps us program exercises that would be more specific to each individual's needs. And we can do this for pretty much every pattern that we label dysfunctional. So if we think back, okay, cervical rotation was one movement I was going to want to look at. Shoulders, both in the functional external rotation and internal rotation. multi-segmental flexion, which is what we looked at here. There's multi-segmental extension, rotation, and then the deep squat. So I'd be able to break out each individual movement pattern and then figure out what's preventing them from performing that pattern or performing it with good quality. And that would just help guide me better with manual techniques or with exercise prescription. Okay.
Okay, so a lot of, I think as we go through this, sometimes you think, well, gosh, that would take 30 minutes out of my physical exam with the patient. Obviously, when we were doing these and as we were training these, we'll walk through that with the patient in just 1 or 2 minutes, kind of going through those things when you kind of get an eye what to look for. Hopefully that gave you a little bit of a sense of just some of the things that we look at in physical therapy when we're looking at just movement patterns and movement dysfunctions. Kelsey is an ultra marathoner, so we're going to have different assessment points for an ultra marathoner than we would for a 90-year-old and different movement screens that we use. But I wanted to be able to give you guys a sense of some of the things that we look at. And I think sometimes, to Rudy's point, we think, oh, they got tight hamstrings. She can't bend over and touch her toes. But actually her hamstring length was, if anything, above normal. It's really a core and motor control issue. So differential diagnosis, even in the movement system, is really important. Just a few quick videos here to show you some other things that we look at. This was a collegiate soccer player with some knee pain. Just having somebody step down the exam room step stool to get up to the table, looking at the poor control of her dynamic knee valgus. Really terrible alignment at her patellofemoral joints. So those are some things you can have somebody quick screen look at if they're having knee pain. Jumping and landing, are they able to do that successfully, or do they come into that knee valgus position? We do a lot of balance assessments, dynamic movement assessments. This is just what's called a Y balance test. We do a lot of sport specific stuff. If we've got a thrower or a baseball player, we can have them do some throws in the clinic and be able to watch their shoulder and also seeing when that movement or that pain presents. Sometimes people don't develop pain until they're tired. So sometimes if we've got a runner that says, I can run 3 miles fine, but when I try to get to that 10K is when I have pain. We'll get them tired. We'll run them for a little bit, and then we'll reassess their movement patterns and see how things change. I'm going to skip through a couple of these. I just want to show these to you. This was an elite high school volleyball player that came into clinic with some shoulder pain. I wanted to show you this as an example of how posture plays into movement dysfunction and pain. So you can see in this, I'm going to pause this for just a second. The dot on the tip of her shoulder is basically her acromion. We're just looking at subacromial space. Volleyball player, she was having shoulder pain. I asked her to just sit. I didn't give her any cues on how she was sitting. And this was her comfortable seated position. I want you to look for a sulcus sign here. I'm just giving a little depression of her humerus, and you're going to begin to see that she's got what would be labeled as, if you were simply looking at this special test and I just had her sit down and pull on her shoulder, I might say she's got some shoulder instability. She's got a positive sulcus sign. Let me back this up just a little bit. And then after we look at that, you can see that there will be a gap there where that humeral head depresses. I just cued her to sit up straight and her sulcus completely resolved. So I wouldn't just immediately label her as a shoulder instability. I would look at her postural strength, of which she didn't have a whole lot. The other thing that's really important to screen in shoulders is just looking at their scapula. Obviously, the scapula is a huge component of shoulder mobility, and I'm just going to let this one play so you can get a sense of what we would label as scapular dysfunction. If you want to see some really good examples of winging, just give her a couple more and just see those inferior angles jutting out. And I like these examples because I think we think sometimes this is just seen in people that are weak. This was an elite competitive high school volleyball player. She was not weak, but you can clearly see she's got a lot of issues going on with her scapular motor control and scapular stability, which was a very important part of our rehab for this patient. That's not pretty. Okay, so again, just some kind of basic concepts in musculoskeletal screening, strength testing, some basic strength grades. And I know these are things y'all are likely very familiar with. We look at strength testing. We'll assess dermatomes, myotomes, and DTRs in our patients when needed. Again, what does a therapist look at? When might you want to send someone our way? Similarly, we'll do a history and physical. We look at that musculoskeletal screen tailored to the patient and their presentations. Pain, gait, and ADL assessments. We look at balance, endurance, overall fitness levels. Neuro screens are something we regularly look at, and we also address comorbidities for our patients. So what are some of those keys to musculoskeletal management? An effective screen is going to be both static and dynamic, looking at a movement screen. Obviously, it's important to come up with a correct diagnosis. Some of those differentiations or appropriate use of imaging. We're going to come to that in a second, but some of the rules I'm sure you've learned are some of the Ottawa rules, Canadian C-spine rules. When to have an appropriate referral, when might you need to send a patient to physical therapy versus into the orthopedic surgery department or orthopedic medicine referral. Differential diagnosis. There are a lot of medical pathologies that mimic a musculoskeletal complaint. And that is one of the things that we're very trained on in PT school, is to begin to develop awareness when we might need to send somebody back to the physician, that it's not presenting as a true musculoskeletal component. That overlay of medical pathology to the MSK system, I think, is really important. I'm not sure how familiar, I'm sure you're quite familiar with these, but just being familiar with things like Ottawa ankle and foot rules, and the Ottawa knee rules. These were initially developed and validated for emergency management, emergency room management, but so often if somebody falls and they think they hurt their ankle, they don't necessarily go to the emergency room. They often show up in your office. So having good clinical decision-making strategies for imaging is really important. So in a traumatic ankle pain, radiographs are indicated if there is point tenderness at the posterior edge or within 6 centimeters of the lateral malleolus, of the medial malleolus, and whether or not they can immediately weight bear up to 4 steps. Traumatic midfoot pain, similarly, radiographs will be indicated if there's point tenderness at the base of the 5th metatarsal or the navicular, and whether or not they can weight bear 4 steps. So if none of those things are present, then studies indicate that we do not need, there's 97.5% sensitivity for whether or not that patient needs imaging. The Ottawa knee rules, age greater than 55, if there's isolated patellar tenderness at the head of the fibula, whether or not the patient can flex their knee to 90. And again, there's that 4 steps department. Can they immediately bear weight and walk into your clinic? Imaging for low back pain. I think this is always a big question. When do I need radiographs of a patient that presents to me with low back pain? There are a lot of studies, and actually that previous slide was taken from American Academy of Family Physicians with the recommendation, and you can probably see it's small, but don't do imaging for uncomplicated low back pain within the first 6 weeks. There are countless studies across different patient populations on this, but basically the studies consistently show that patients with no back pain often show anatomic abnormalities on imaging. And on our end in the therapy world, we routinely see that patient that's perseverating on their imaging. They found something on my MRI. Therapy's not going to help. Medicine's not going to help. I got to go see surgery. Or there's no need for me to come to therapy. I don't need to get stronger. I don't need to lose that extra 100 pounds. I have a herniated disc. They saw it on my MRI. I just need to go to orthopedic surgery. Very commonly, most patients without any pain whatsoever will show some kind of anatomic abnormality on imaging that may or may not correlate with their symptoms. There are, of course, risks associated with routine imaging, not only radiation exposure, but this labeling phenomenon. And that's been studied repeatedly and shown to worsen the patient's sense of their well-being. An increased rate of imaging directly correlates to an increased rate of surgery. This, I just grabbed a couple individual studies, one that looked at occupational related back pain, which I'm sure you see in your clinics regularly. Occupational related back pain that had an early MRI had an 8-fold increased risk of surgery. So this sense of immediately diving into imaging absolutely has the potential to greatly influence the outcome on the patients. There was another one that looked at non-occupational incidences of just patients with low back pain who had an MRI, and they were twice as likely to undergo surgery as compared to patients who simply had plain film imaging. So again, using really good differential diagnosis to determine when routine imaging is indicated. This was simply another study, a meta-analysis, but it looked at the difference in outcomes of patients who had immediate lumbar imaging versus usual care. And that usual care is, according to AAFP and the family practice guidelines, show that immediate imaging is not necessary within the first 6 weeks in the absence of red flags. So imaging of the lumbar spine, according to this meta-analysis, indicate that before 6 weeks, it does not improve outcomes, it increases costs, and it should only be safe for patients for whom non-invasive conservative regimens have failed and surgery or injection is being considered. These are just a few studies, just wanted to highlight real quick of what is some of the evidence behind conservative care. So when a patient says, oh, I don't want to go to therapy, I just want to go straight to orthopedics. There are lower costs associated with low back pain when treatment begins with therapy versus imaging. And that seems obvious, but this was a study done in 2015. that looked at physical therapy versus imaging as that first strategy. And outcomes were similar, but obviously cost much reduced when we started with therapy versus imaging. Early PT reduces costs and resources compared to later referrals. So the more quickly we can get them into therapy, as opposed to, I think sometimes we see patients after they got in to see their primary care physician and they waited 2 weeks to get into an orthopedic physician, and then they waited another week to get into physical therapy. So 3 weeks later, their pain is a lot more potentially difficult to resolve than when they immediately enter the conservative management system. This was a big study that received a lot of talk that came out in the Annals of Internal Medicine in 2015. And it was a randomized controlled trial. And the conclusion of that was, quote, PT was effective as surgery for easing the pain of spinal stenosis. So that one created a lot of buzz. Another one that created a lot of buzz and has been looked at multiple times, this was just one I pulled from 2015, was looking at arthroscopic knee surgery, and indicated that for the, quote, just degenerative knee, that there was no long-term benefit for arthroscopic knee surgery for knee degeneration, and the outcomes for conservative management and physical therapy were similar. Another one looking at FAI, femoroacetabular impingement and hip pain, no significant differences at 2 years between surgery and physical therapy for FAI. So hopefully through this just gives you a little bit of information on what we do over here in the physical therapy world, and the preponderance of evidence that exists of how conservative management helps across such a continuum of care of musculoskeletal patients. So how do you send us somebody? Just simply put a referral in for physical therapy. Evaluate and treat. I often get a lot of questions for docs about what they need to write. Really just place and evaluate and treat. The really helpful information from us is if there's any medical diagnosis, relevant surgical or medical history. It's great being here as part of the UT system because we can read all of your documentation in Epic. We can garner a lot of that information. And then once we evaluate a person, we'll send you back a plan of care, or our consultation will be sent back to you. You'll often probably get tired of signing them because Medicare does require your signature on this plan of care. Insurance often dictates the allowed number of visits or authorization. So sometimes we'll receive a referral from a physician and it'll request 3 times a week for 12 weeks or whatever it might be. That patient's insurance plan will often dictate how frequently we can see them. So do be aware that sometimes when changes are made to those referrals, it's often because of what their insurance allows. We do now have direct access to physical therapists in the state of Texas. We were one of only 2 states that did not have any form of direct access until it was approved in September of 2020. So a patient now can come to see a physical therapist in Texas without a physician referral. There is a 10 business day limit on that, and the therapist does have to be a DPT, a doctor of physical therapy. If we want to go beyond those 10 visits, then we need a physician referral. So often when we have patients call and they want to come see us without a physician referral, we'll recommend that they then follow up with their primary care physician, and we will of course always ask who that is and send them a plan of care and their consultation report as well. This is just from our UT Health website. We are here in physical therapy to help you at UT Health. Our main clinic is here at the Mark. We also have a location at our Hill Country Clinic. And for those of you that are familiar with the building that we're building at Park West, we will have a physical therapy clinic there at Park West as well. And we also have a physical therapist who's embedded at UTSA, working with the athletic department there at UTSA, seeing their athletes. Just some references here, so I'll just skip through those. And now I will see if we can click back up here and see if y'all have any questions for us.
There was one question when y'all were showing the videos. Someone asked if the evaluation would take over 15 minutes in an elderly person.
Absolutely. So in the orthopedic world here, we book our patients on the 30 minutes. Evaluations generally, so we book on the 30 minutes, we typically spend 60-ish minutes with our patients. So we're always running a little bit of a dovetail throughout the day. Our neurotherapists and our public health physical therapists have one-on-one patient slots for an hour. So yes, we absolutely manage multiple patients at once throughout the day, but typically we spend about an average of an hour with each of our patients. We also have a great care team. As Rudy mentioned, that particular patient example was one of our employees who's now moved on to PT school. Again, she was training for an ultra marathon and was having a lot of shoulder and low back pain and some issues. So we were just doing an assessment on her and decided to capture a little video for training purposes. In the clinic, that would move a whole lot faster, but we also have staff like Kelsey was at the time, who are physical therapy techs, So they'll assist us in helping carry patients through exercises, bringing patients back, and help with that flow so that we can spend time needed to do a good true examination on our patients. Anything else? Well, hopefully y'all guessed correctly, or were not guessed. You knew correctly the questions of the musculoskeletal screen initially. And if you were thinking tight hamstrings on the screen, it gave you a good sense of some of the other things to look at or just to think about. Hopefully that gave you a little bit of a sense of just some things you can quick screen. And if you identify pain, movement patterns that just don't seem quite right, send them over to us. Let us break that down a little bit more. We really appreciate here the collaboration we have with all the physicians on our team, but really with primary care, we're technically part of the Department of Orthopedics. We only see about 50% orthopedic patients. We have about 40% of our patients that come from our primary care practices. So it's a huge referral into our system at both locations. And we really appreciate the collaboration with all of our family medicine providers and primary care team. So if no other questions, that's what we've got for today. If we can be of any assistance to you, please don't ever hesitate to reach out.
Okay, with that, I just want to thank you. I know we really wanted to do this presentation in person, and maybe we can plan for that in the future, but definitely appreciate you guys presenting for us today. And thank you for everybody who attended. I did put in the link for the presentation evaluation, but thank you again, everybody, for today, and I hope you have a good afternoon.
Thank you so much.